Hi, Volodymyr. Or whoever it is.
Hello, everyone.
Right, you're not. Hello, Florin.
Hi, do you hear me?
Yes, I hear you.
Perfect. Nice meeting you again.
You too.
Hello, Professor Jorge.
Hi.
Glad to see you. Thank you that you agreed to participate in this webinar. Доброго дня, шановні колеги.
Good afternoon, my dear colleagues, and you're about to connect to the webinar about macrolides, tetracyclines, and aminoglycosides, and let us wait for the other participants to join in the course of a few minutes. So we'll get started with the webinar.
Ще раз всіх вітаю. Я бачу, що кількість
I
слухачів
would like really to extend my greetings to you all. So the count of all participants is over 200, and we will make a start of our webinar online lecture, so devoted to macrolides, tetracyclines, aminoglycosides, polymyxins. So their range of action, so resistance mechanism, and then potency, pharmacokinetics, pharmacodynamics, and clinical indication. So a very well-experienced professor, expert Florian George Horhat from the University of Medicine and Pharmacy, named after Victor Babesh, Timișoara, Romania, and he is also in charge of the pediatric hospital emergency care Louis Tsukan in Timișoara, Romania. So he is here to share his experience, that of the clinical doctor and that of the lecturer, to talk you through the pharmacology of these antimicrobials. So this lecture is arranged within the framework of the webinar's European experience of the IPC introduction, so perspectives for Ukraine, in the view of the antimicrobials utilization since 2023. We've been doing these webinars thanks to the financial support of the US CDC and ICAP at the Columbian University, US. And you would like really to say separate thanks to the professors and to the experts from the EU agency UKIC and XMID, the ones who are here to share their experience and who join efforts to hold these webinars. So the agenda of the meeting to take for as long as 1 hour, and we have simultaneous interpretation ongoing. So my request to you, so please leave through the slide. So please do your simultaneous translation settings. So stay on your Ukrainian channel. So to keep abreast of the webinar, so to last for 60 minutes, and after the webinar, questions and answers, and feel free to ask your questions in the chat. As far as the agenda, the time shall allow, the esteemed professor will be able to take the questions, the ones that we don't have enough time to answer for. So Florin has kindly promised so to reply in writing later on, so prior to starting of the webinar. So I just would like to say that the series of the webinars shall be ongoing still more so yet, and so it's not really to let go yet another webinar that will happen still soon. So what we suggest doing is actually sign up for our UPHC webpage in the Facebook. So we update our announcements and keep abreast of the developments of the webinar. The lecture itself shall be recorded, and in the course of a few days it will be available, uploaded on the UPHC website with all the other score of the materials uploads, and thus we will have a library of our materials uploaded there, so you will be able to tap in and see and have a look at those uploads. So let's make a start. So Florin, the floor is all yours.
Thanks for the introduction. Great introduction. I feel like a superstar. I want to say all the best from sunny Timișoara. My name is Florin Horhat. I'm here with part of my team. Cristina Blaga is near me. We have full support. Thanks for the full support of ICAP and CDC for letting me discuss about this topic. We will start talking about tetracycline, aminoglycosides, macrolides, and polymyxin. I will speak in English. You have the slides translated into Ukrainians. Because I cannot derelate the slides, I will ask Sarah to. I will say next slide, and then you'll go to the next slide. So we are starting with the agenda. If you want to go to the next slide, Sarah. We are talking about the mechanism of how they became resistant. The antibiotics works on inhibitors of protein synthesis. Here is a discussion about tetracycline, aminoglycosides, macrolides, clindamycins, and chloramphenicol, which and then we have the inhibition of cell walls membrane functions, which is amphotericin B and polymyxin. If you go into the next slide, we are thinking to go to protein synthesis, which is a number of antibiotics which exerted their antimicrobial effects by targeting bacterial ribosomes and inhibiting bacterial protein synthesis. Next slide, please. The bacterial ribosomes differ structurally from mammalian cytoplasmatic ribosomes, and they are composed by 30 subunits or by 50 subunits. The mammalian ribosomes have 40 and 60 subunits. In general, the selectivity for bacterial ribosome minimizes the potential of adverse consequence encountered with the disruptions of protein synthesis in the mammalian host cells. However, the high concentration of drugs such as chloramphenicol or tetracyclines may produce toxic effects as a result of interactions with the mitochondrial mammalian ribosomes, since the structures of mitochondrial ribosome are more closely resemble to bacterial ribosomes. So if you go to the next slide, you'll have a quick reminder about the ribosomes, which are the macromolecular machines that are found at all cells that are performing biological protein synthesis. So we have three sites for the target RNA binding. We have the peptide, the amino acid, and the exit sites. You saw it on the slide. The inhibitors of methionine target RNA, it is bound at the P site, the peptide sites. The first step of elongation is the binding of the next amino acid's target RNA to the A site by pairing with the second codon of the microRNA. So if you go to the next slide, we'll start with the tetracyclinome, which is derived from the Streptomycetes bacteria. Next slide. It consists of 4 focus rings with a system of conjugated double bonds. The tetracyclinome, it is more used as a cream, as a topic, a local topic. The substitution of these rings alter the individual pharmacokinetics and spectrum of antimicrobial activity. If you go to the next slide, you saw that the tetracycline enter via passive diffusions and also by an energy-dependent transport proteins mechanism, which is unique in the bacterial inert cytoplasmatic strain. The tetracycline binds reversibly on the 30S subunits of the bacterial ribosome. These actions prevent bindings the target RNA to microRNA ribosome, which is complex things, and thereby they inhibit the bacterial protein synthesis. So the tetracyclines, it binds reversible on the 30S subunit things. That's a thing you should remember. If you go to the next slide, you'll observe that tetracycline is bacteriostatic antibiotics. You know that we have 2 types of antibiotics. One of them, which is bacteriostatic, it stops developing the bacteria, and another one which is bactericidal, that means it kills the bacteria. This type of bacteria, it's bacteriostatic, and it is quite effective to a large number of microorganisms, which includes gram-positive and gram-negative bacteria, spirochetes, mycobacterium, and also a source of atypical species. It is used as a treatment for Lyme disease. You know that it's a spirocheta caused by Borrelia burgdorferi. This is transmitted via contaminated ticks. Now it's a summer disease. It is commonly found during the summer, and the treatment is doxycycline, for example, is one of the preferred therapeutical options. In Romania, this is the guidelines. We use the doxycycline as a single use, or you can use it second use. Mycoplasma pneumonia, I don't know if you have it, but we have some cases of Mycoplasma pneumonia, which is a border bacteria. It's extremely small. They are hard to, they cannot be cultured. You have to do molecular biology to see it. The treatment is doxycycline or macrolide, which is effective. We are talking about the silent sexual transmitted disease like chlamydial infection, ureaplasma, mycoplasma infection. This is sexual transmitted disease which cannot be seen because they didn't have clinical symptoms in most of the cases. Almost 90% of all the cases remain subclinical. That's why the chlamydial it's a major cause of sexual transmitted disease in Europe, and it produces so-called the non-gonoccal urethritis, and is producing pelvic inflammatory disease, which is a second case of infertility to young females. And that's why the treatment is doxycycline for 3 days. We don't have any cases of cholera, but in some countries they are still active. So the treatment of Vibrio cholera from infected water or food is doxycycline also. The treatment of the acne and infection of chlamydia is doxy. So this is things to take as a message to take away. If you go into the next slide, you'll see that the resistance of the tetracyclinum commonly occurred naturally, and it's appeared to on efflux pump. Another mechanism of bacterial resistance is including the enzymatic inactivation of the drug and production of bacterial proteins that prevent tetracycline from binding to the ribosome. Remember one thing: if you have a resistance to tetracycline, it doesn't mean you have resistance to all other tetracyclines. So the resistance is it's not conferred to the entire group. So the resistant mechanism is the efflux pump and the inactivation of the drug by different enzyme and the alternative of alteration of drug target. So if you go to the next slide, you'll see some products like yogurt, milk, and antacids. It's highly problematic if you use it. If go to the next slide, please, Sarah. If you administrate it with that, you will decrease the absorption of the antibiotics. So the tetracycline are absorbed after oral injections. So we have here a graphics. What happens if you have an empty stomach, and what's happened if you take an antacids, or if you have a glass of milk. If you have a glass of milk, the absorption of the tetracycline is so low that it doesn't have any effects. So never administrate. Be very careful and ask your patient to not take it with milk, yogurt, and other anti-acid things. That's a major problem if you have on case like this. Remember that doxycycline and minocycline are available both in oral and intravenous preparations. But other products that reduce the absorption is magnesium, aluminum antacids, and iron supplements. So milk, yogurt, antacids, iron supplements, and magnesium can reduce the absorptions. If you go to the next slide, you'll see that the tetracycline concentrate well in bile in liver, in gingival fluid, in skin, and in kidney. So what's happened, for example, if you administrate tetracycline to small children, you know, the complication of them, it's I'm sure that you remember, you have that yellow teeth. So be very careful, because they are absorbed into in the place where this high concentration of calcium, so into the bones and into the dental smolt. Only minocycline and doxycycline achieve therapeutic levels in the CSF fluid, cerebrospinal fluid. So if you suspect you have a patient in infections and you should administrate them, choose minocycline or doxycycline. The minocycline also achieve high levels in the saliva, in tears, and it is perfectly to be used as eradicating the meningococcal carrier state. That's an important way how to eradicate. Be very careful that all the tetracycline cross the placental barrier, and it's concentrated in frontal bones and dentitions. Okay, if you go to the next slide, you'll see the elimination of the tetracycline and the doxycycline are not hepatically metabolized. The tetracycline, it is primarily eliminate uncharged in the urine, where minocycline undergoes hepatic metabolism and is eliminated to a lesser via the kidney. In renally compromised patient, doxycycline it is preferred. So if you have a patient with chronic renal disease, doxycycline is the one which can be used, because it is primarily eliminated through biles into the feces. Also can be treatment of complication of biliary cases. That's it's one thing. If you go to the next slide, I will show you some adverse effects like gastric problems, nausea, abdominal pain, abdominal bloating, indigestions, burning, loss of appetite. That sometimes is good. But the gastric discomfort, it's a major sign for that, because it irritates the gastric mucosa. Another symptoms which can appear is the esophagitis, which can be reduced if you take it with food, okay, other than dairy products, or with fluids. And another important thing, use capsules rather than tablets. That's a key home message, because tablets, it's easy to be absorbed and that doesn't produce esophagitis. Tablets, it's more powerful, not more powerful, more aggressive to esophageal tract and thing. And note one thing, that tetracycline should be taken only on empty stomach to be absorbed, to be correctly absorbed. If you go to the next slide, you'll see what I discussed is the tetracycline signing. So never administrate to children lower than 8 years, because you'll have problems. You'll have a problem at malpraxis problem, or all sorts of other things. And the absorption of tetracycline into the bones is irreversible. Once it is produced, they cannot be reversed. Okay, so as another message is tetracycline, it is used as limited as possible into pediatric use. We never used tetracycline. We didn't have it in our pharmacy, in our hospital, only as a local thing, a topical thing. Okay, if you go to the next slide, we have another adverse effects, which is hepatotoxicity. which is rarely and appear especially to pregnant female with pre-existing hepatic disruptions or renal impairment. If you go to a next slide, you'll see that you can suffer extremely severe sunburn if the patient take tetracycline and stay to the sun. They absorb the sun so quick more often, and that's why you should use adequate sun protection. So use cream with HPV, 50% 50 HPV or SPF, sun protection factor. That's the thing, as higher as is possible. We have it in Romania only maximum 50 SPF factor. So the patient should be advised to wear adequate sun protections. Never tell your patient never to stay on the sun if they are taking tetracycline. If you go to the next slide, you'll see that they can suffer different other vestibular dysfunctions, from vertigo, tinnitus, dizziness, occurs particularly, especially to minocycline, which concentrate into the endolymph of the ear and affects the functions. Doxycycline may also cause the vestibular dysfunctions, that's for sure. And rare, if you go to the next slide, you'll see that it produces pseudotumoral cerebrin, which is benign intracranial hypertension. It is rarely found. The image is blurred, and it is characterized by headache. This is a reverse thing, so it's not things which the patient remain with it. So if you stop administrating the drugs, the patient will feel better, and they will start having they will not have any other symptoms. So it's the patient doesn't remain with permanent sequelae. So as a last slide for this is a contraindication. The next slide. We have tetracycline should not be used at pregnant female, at breastfeeding woman, and children less than a year. Take it like this, and you'll remember. Never administrate metronidazole, chloramphenicol, aminoglycosides, and tetracycline to pregnant woman. Never administrate to breastfeeding woman and children less than 8 years old. So if you go to the next slide, we'll start with aminoglycosides, which is used for the treatment of serious infections due to aerobic gram-negative. Going to the next slide, you saw some slides how it looks on biochemical products, because we are all biochemical products. They have two amino acid sugar joined by a glycosidic linkage to a central hectose nucleus. Aminoglycosides are derived from Streptomycetes or from Microspora. So the mechanism of action, it is found in the next slide, which aminoglycosin diffuse through porins channels in the outer membrane of the susceptible organism. These organisms have an oxygen-dependent system that transport the drug across the cytoplasmatic membrane. Inside the cells, they bind the 30S ribosomal subunits. The antibiotics that disrupt the protein synthesis are generally bacteriostatic. However, aminoglycoside is the only one which is bactericidal. The bactericidal effect of aminoglycosin, it is concentration dependent. Efficiency is maximum, is depend on the maximum concentration, which is called the Cmax of drugs above the minimum inhibitory concentration of the organism. For the aminoglycosides, the target of Cmax is 8 to 10 times the measure of the MIC. They are also exhibit a post antibiotic effect, which is called the PAI, the post antibiotic effect, which is continued bacterial suppressions after drug levels fall below the MIC. The larger the dose, the longer the post antibiotic effect it is. Because of these properties, the extended interval dosing, a single large dose given once daily, is now more commonly used than divided daily dose. So you increase the dose and you cover the entire day. That's easy. Remember that aminoglycosides under the new guidelines, it is not used as a single drug. It should be used in a combination, especially with beta-lactam. In our hospital, we are not using aminoglycoside. That extremely rare, and in combination with beta-lactams to high treatable resistance. We are a large pediatric hospital. We have 561 beds, but we have several different departments. We have bone marrow transplant. We have the biggest oncological department in Romania. We have renal part, especially dialysis patient, complicated patient. We have a big surgical department, ENT, surgical, orthopedics, polytrauma, burn department, neurosurgery, maxillofacial department, and we have pediatrics, and also we have a number of beds for newborn, small newborns from 600 grams to 2.5 kilos. That's from premature. We have the largest compartment, so we have a lot of complicated cases, but we still experience a low resistance to many germs. We have some cases of Klebsiella, which was imported, not from our hospital, and we still have some Stenotrophomonas, especially to the bone marrow transplant and transplant the complicated patient, and we are still looking for the from where it comes. So if you go to the next line, you'll see that the spectrum of aminoglycosides goes perfectly against gram-negative aerobic bacteria, and including the multi-resistance one like Klebsiella species, especially pneumonia and Enterobacter species. But remember, they are oftenly should be combined with the beta-lactam antibiotics to employ a synergic effect, particularly to in the treatment of Enterococcus faecalis and Enterococcus faecium infective endocarditis. We have 4 commonly aminoglycosides used. We have amikacin, gentamicin, which is the simple aminoglycoside, tobramycin, and streptomycin. Remember, the synergic aminoglycosides may be added to a beta-lactam to produce the synergic effect, especially against Enterococcus species, or in case of Streptococcus agalactiae, to highly resistant Streptococcus agalactiae. We don't have resistant Streptococcus agalactiae. We do screening to all pregnant female. In Romania, we have a national screening process. And another important thing is to treatment the highly resistant germs like Acinetobacter, Klebsiella species, and Pseudomonas aeruginosa. If you go to the next line, you see the resistance can be made on several methods: efflux pump, and decrease uptake and modification and inactivation of plasmid associated synthesis of enzymes. Each of these enzymes has its own aminoglycoside specificity. Therefore, cross resistance cannot be presumed. Aminoglycoside is less vulnerable to these enzymes than the other antibiotics of this group. So a bacterium resistance to one macrolide might be resistance to other in the same class. So that's a key home message to take. It's due to the cross resistance things. If you go to the next slide, you saw that due to the pharmacokinetics, you have absorptions, the highly polar polycationic structures of the aminoglycosides prevents adequate absorption after oral administrations. Therefore, all the aminoglycosides except neomycin must be given parenterally to achieve quantity. The levels of the serum should be adequate. The neomycin is not given parenterally because they produce severe nephrotoxicity. So it is used as a topical antibiotics for skin infections, or orally for colorectal surgery. If you go to the next slide, you saw that the distributions of aminoglycosides have similar pharmacokinetic properties due to their hydrophily. The tissue concentration might be subtherapeutic, and the penetration into most body fluids it is variable. So remember that the streptomycin and amikacin, it is poorly absorbed into the gastrointestinal tract. The gentamicin, it is used as a treatment, local topical treatment in eye infections like local eye drops and ear infections, external otitis. The tetracycline, it is also used as a topical antibiotics in the eye infections, and in case as an inhalatory things to the patient with pseudomonas infection, especially to the patient with cystic fibrosis, which develop on complication of against the lung, and neomycin. It is used before surgery. The concentration in the cerebrospinal fluids are inadequate, even in the presence of infrared meningitis. All the aminoglycosides close the parenteral barrier, that's things, and may accumulate in fetal plasma and amniotic fluids. If you go to the next slide, you saw that the drug is eliminated more than 90% through urine. The accumulation occurs in patients with renal dysfunctions, and those judgment it is required. This is a funny jokes about the drug extractions and why we are not real brothers, because we are renal brothers. That's the funny things about it. If you go to the next slide, you saw that the adverse effects of this drug, it is Genta, Tobra, Amica plasma level. It is impressive to ensure adequate dosing to a minimal dose related toxicity. In elderly, they are producing nephrotoxicity and ototoxicity. On the next slide, you saw that why it's producing ototoxicity, because it is more more commonly found in the plasma in the internal ear, in the perilymph of inner ear. And be very careful that the deafness may be reversible, as has been known the effect of these things, especially in young children and in fetus. That's why you should never administrate to gentamicin to young children. We have some malpractice process in Romania due to administration of gentamicin to small children, which led to deafness, irreversible deafness. So in our hospital, we have two process due to these things, and nobody. This is an old story in the old times, but the problem still remains. So be careful of administering gentamicin to children. I will never recommend to do it. The new studies say that also in adults can appear. I saw some new articles, and they say never administrate. Try to avoid administration gentamicin as less as possible. So vertigo is also on complication, and it's appears especially to a patient which receiving streptomycin. Another adverse effect is on the next slide. You'll see the nephrotoxicity. The renal functions, it is disrupted, and because it destroyed the proximal tuber cells and destroyed the kidney from mild to reversible renal impairment, and in some cases it can be produced acute tuber necrosis, which is a highly risk complication, which is an irreversible one. Another adverse effect is on the next slide, is the neuromuscular paralysis, which is associated with a rapid increase in concentration. For example, high dose of infused over the short period, or concurrent administration with neuromuscular blockers. You can use some antidotes, which is the calcium gluconate and neostigmine, which can reverse the block and cause neuromuscular paralysis. That's the only way you can do it. And not the last. On the next slide, you'll see the allergic reactions. The contact dermatitis is commonly reactions with the neomycin. It is applied on the skin, the redness, and so be very careful on the first administration and of neomycin in as a cream, as a topical cream, especially to small children. The clinical studies, you'll find it on the next slide, is more used, are not used as monotherapy in the modern clinical practice. It can be used only for urinary tract infections. That's the EUCAST guideline told us. It can be used in our country. It is not used. It is not accepted. We have some local guidelines, and due to the guidelines, we are not using it. But it can be used also as inhalatory treatment, as a monodoses in patients with cystic fibrosis. This is a therapy which helps patients with cystic fibrosis. You know that patients with cystic fibrosis have chronic problems of pulmonary problems. We have one of the largest cystic fibrosis centers in Timișoara. We have more than 60 patients in as a chronic patients, so we have quite experience in cystic fibrosis treatment. There you'll find the different type of infections with Stenotrophomonas, Burkholderia, Pseudomonas, Acinetobacter, and some other Klebsiella species, but Pseudomonas is the superstar of these infections. We're going to another topics which start on the next slide, which is macrolides, which is a group of antibiotics with macronic lactone structures to which one or more desoxy sugars is attached. So we have 3 stars here. We have erythromycin, azithromycin, and clarithromycin. The erythromycin, you know, it is the first of these drugs, which it is still used as a first choice drug in case you have an alternative, as an alternative to the patient which have penicillin allergy. So be very careful when you administrate any penicillinum or different type of penicillinum to your patient with streptococcal infections, especially because they can produce suddenly reactions to them. That's if you have it, you can alternatively use erythromycin. The clarithromycin, it is a methylated form of erythromycin. Azithromycin, it is a larger lactone ring, have some other features commonly improve against erythromycin, but mostly they are part the same, they're having the same structures. On the next slide, you'll saw that the mechanism of actions, the macrolides bind irreversible to the 50S subunits of the bacterial ribosome, those inhibiting translocation steps of protein synthesis, generally considered to be bacteriostatics. But in case you increase the dose, they can be transformed and become bactericidal. So normally they are bacteriostatic, but the dose, if the dose is higher, it is transformed and to be used as bactericidal. Their binding site, it is either identically in close proximity to that clindamycin and chloramphenicol is doing. If you go to the next slide, you saw the antimicrobial spectrum of this. The erythromycin is the drug choice against penicillinum, the same thing, in the same way as penicillinum G, but it is used only if the patient have allergic to penicillinum. It covers perfectly the legionellosis disease. You know, it's a pulmonary disease. It comes from the air conditioning, not clean air conditioning machines. That's why the central air conditioning machine can become a major health problems to hospitals and to stores. That's why you need maintenance, cleaning, and things. Mycoplasma pneumonia, which is called atypical pneumonia, commonly take from the air conditioning, and during the flights we have a professor of cardiology which all the time when they fly more than 8 hours they develop an atypical mycoplasma with mycoplasma. So he have other collateral disease. Of course, he's a little bit fat. He's overweight with more than 20 kilos, and he have some hemophilic problem, and that's why he experienced some things. But the doxycycline or azithromycin are preferred as a therapeutical option. Chlamydial infections, of course, this is a treatment to azithromycin or doxy. And not the last one, Corynebacterium diphtheria. We experienced in the last 6 months a large number of Corynebacterium diphtheria infections due to the reducing number of the patient of the children which is vaccinated. We experience a reduced number of new the parents refuse to vaccinate the children, and that's why they have we will have major problem in the next 10 years, because we will not have the umbrella, the 95% of the vaccinated problem. So we will experience new and new major problems. You know, the allergy, the penicillin symptoms, it's wheezing, difficult breathing, swallowing, and of course different spots on the skin and high sensitivity. And anaphylactic shock can appear suddenly, and that's why you should be very careful to penicillin allergy. If you go to the next slide, you'll see that the clarithromycin it is perfectly used against Haemophilus influenza, and it goes perfectly against chlamydia, legionella, moraxella, ureaplasma species. You know, we have Oraxella ureaplasma, it's a sexual transmitted disease. Mycoplasma ureaplasma, it's really small. And also clarithromycin, it is considered as a drug choice for Helicobacter pylori. I don't know which is the incidence of Helicobacter pylori in our countries, but in our country we experience a large number of Helicobacter pylori infections. So if you go to the next slide, you'll saw that the azithromycin, it is less active against Streptococcus than Staphylococcus than erythromycin, azithromycin. It is far more effective against respiratory infections due to Haemophilus influenza and Moraxella catarrhalis. I hope you identify Haemophilus and Moraxella. We identified quite a large number of Moraxella and Haemophilus as a nasal carrier to patient. We are using for identification 2 methods. We are using Malditov. We have a Malditov from Bruker, but we also have a new tools which is produced by Halifax. It's an IDAN, which is fluorescent. It's a infrared method. Each bacteria have a specific infrared fingerprint, and it's very easy to be used, and it is used especially on gram-positive bacteria. So if you identify the azithromycin can be a drug choice for them. If you used a lot of azithromycin, it will result a large number of resistance, especially to Streptococcus pneumoniae. We experience a lot of infections with Streptococcus pneumoniae, and remember that azithromycin, it is preferred as a therapy against chlamydial infections. We have rare case of Mycobacterium avium, but it can be treated with azithromycin. If you go to the next slide, you saw that in the ring of fire, microbes and antibiotics, the antibiotics resist, and the resistance appears of 3 mechanisms: the inability of the organism to take up the antibiotic, the presence of efflux pump, a decreased affinity of the 50S ribosomal subunits for the antibiotics, which results from the methylation of an adenine in the 23S bacterial ribosomal RNA in gram-positive. And another mechanism is the presence of plasmid-associated erythromycin esterase, which is specific to gram-negative bacteria like Enterobacteriales species. The resistance of erythromycin has been increasing, particularly to Streptococcus pneumonia. As the pharmacokinetics times, it is found in the next slide, where you saw that the erythromycin base, it is destroyed by gastric acid. Those either enteric-coated tablets or esterified the forms of the antibiotics should be administered to your patient, or it is well absorbed by oral administrations. Clarito or Zitro are stable in the stomach's acid and they are rapidly absorbed. Be very careful that the food interfere with the absorptions of erythro and azitro, but it can be really useful to give the patient some food if you are administering clarithromycin. So not administrate food to the patient which take erythro and azitro, but the food is the potential increasing factor for the patient which takes the clarithromycin. Remember that the erythro and azithromycin, it is available in intravenous formulation. On the next slide, you'll saw that the erythromycin distributes well to all blood fluids except CSF. If you have a patient with a CSF infection, never administrate erythromycin. All four drugs, it is concentrated in the liver. On the right hand, you have the half-time hour. That's an important factor. The azithromycin concentrates very well in the neutrophils, macrophage, and fibroblasts, and serum levels are low. It has the longest half-time life of all these antibiotics. And that's why it can be administered as a single dose, because you cover a lot of hours. The elimination you will find in the next slide. The erythromycin and the tetracyclines are extremely metabolized into the hepatical cells. They inhibit the oxidation of a number of drugs through the interactions with the cytochrome P450 systems. The excretions, it is found also in the next slide, where erythro and azitro are primarily concentrated at excretum into the bile. So if you have a bile problems, you can administer easily these drugs and they are partially reabsorbed through enterohepatical circulations. In contrast, the clarithromycin and its metabolites are eliminated by the kidney as well as in the liver. The dose of this drug should be adjusted in the pairs with renal impairment. As an adverse effect, you'll find in the next slide, and you saw that the gastric distress and motility is one of the common adverse effect on macrolides and may lead to poor patient compliance, especially to erythromycin. That's why the patient which take erythromycin doesn't want to take it, because they experience a lot of gastrical side effect. Clarithromycin and azithromycin, it is more tolerant, but still the patient tell them that they have a metallical taste and they doesn't want to take it. They all the patients who take it, they say, I will take no if you say, if you give me again. So explain the patient they can suffer of this side effect if the patient is well announced and correctly informed. They will cross more easy to these symptoms that they are not well informed. And that's why perhaps speaking with the patient is one of the most key role of us as the doctors. Remember that high dose of erythromycin leads to smooth muscular contractions that results in the movement of gastric consent of the duodenum and other adverse effects, sometimes used therapeutical for the treatment of gastroparesis or postoperative ileus. In the next slide, you saw the cholestatic jaundice. This is a rare side effect, especially used after it is used to erythromycin. It is has been reported with other formulation, but it's not so common. As another adverse effect is the ototoxicity, which is on the next slide. Transient deafness has been associated with erythromycin, especially in high doses. So high doses can result to deafness, but it is transitory. The azithromycin has also been associated with irreversible sensory hearing loss. So if it's possible to not administer to children, it is perfect. Be careful to ototoxicity. The contraindication, it is found on the next slide. Be careful to hepatical dysfunction should be treated cautiously with erythromycin, azithromycin, because these drugs accumulate into the liver. So if it accumulates into the liver, be very careful to not administer to the patient which have chronic liver disease. Severe hepatotoxicity have with erythromycin has been limited use given the availability of as an alternative therapy. These macrolides may prolong the PC interval and should be used with cautions at all the patients with proarrhythmical conditions. So we have some problems of we have also a cardiology department in our hospital, one of the biggest pediatric department, and they suffer some problems with the QC. So be careful because they are more longer than normal, and the clinicians start to become wild sometimes. The drug interactions, and you'll find on the next time, claritro inhibits the hepatic metabolism of a number of drugs, which can lead to toxic accumulation of these compounds. The side effect, it's anxiety, hallucination. In case of food poisoning and toxicity, you have different nausea, vomiting, electrolytes imbalance, and can be worse by other medications. They're extremely toxic to liver, So be very, very careful to patients with chronic diseases, liver chronic diseases like hepatitis and other patients who consume a lot of alcohols and other kind of chronic diseases. The interactions with digoxin may occur. In this case, the antibiotic eliminates special of intestinal flora that ordinarily inactivate digoxin, that thus leading to greater reabsorptions of the drug from the enterohepatic circulation. On the next slide, you see the last but not the least important things, the cell membrane inhibitors. We are thinking about some antimicrobial drugs selectively interfere with synthesis of the bacterial cell walls. This cell walls is compounded by a polymer which is called the peptoglycan. You know, the peptoglycan, it is different on gram-positive to gram-negative bacteria. The glycan units join to each other by peptide cross links. To be maximally effective, inhibitors of cell wall synthesis require actively proliferating the microorganisms. They have a little or no effect on bacteria that are not growing and dividing. The most important member of this drug are beta-lactam antibiotics, names vancomycin and daptomycin. We are starting to discuss about the polymyxin, which is found on the next slide. The polymyxin are cation polypeptides that binds to phospholipids and on the bacterial cell membrane of gram-negative bacteria. That's the biochemistry of the polymyxin. Looks amazing. Looks like a map. You have here on the left side down colistin resistance of this. On the next slide, you'll have the mechanism of actions. The polymyxin have a detergent-like effect that disrupt the cell membrane integrity. They wash the membrane and they can enter inside and leading the leak of cellular component, and ultimately they destroy the bacteria. So we remember this thing is like a detergent light effect. The spectrum, it will be found on the next slide. You'll have a polymyxin, which is dependent, which is bactericidal, and it goes perfectly against clinically important gram-negative bacteria. Pseudomonas coli, Klebsiella, Acinetobacter. However, alteration of cell membrane lipids allow many species from Protea species, that not only Proteus, we have Proteus, Providencia, Serratia, Morganella, which is resistance intrinsically to, they have naturally intrinsic resistance to this polymyxin. So we have two forms, which is found on the next slide. We have polymyxin B and colistin. I know that colistin in some countries it is used a lot. In Romania, we have some hospitals which overuse the colistin, especially to intensive care department, to high treatable antibiotics, germs. Polymyxin B is available in parenteral, ophthalmic, otic, and topical preparation. Colistin, it is only available as a prodrug, Colimeta sodium, which is administered intravenous or via a nebulizator by inhalation. Be very careful that colistin require high dosage of antibiotics, not normal doses. On the next slide, you'll saw the adverse effects. The use of these drugs have been limited for a long time due to the increased risk of nephrotoxicity and neurotoxicity. However, with the increase of gram-negative resistance, they have seen the resurgence in the use and now commonly used as a last barrier treatment, as the hope of the saving method. But be very careful in using and be careful at side effect, because it's really important to maximize the effect of this agent, to use the right time, the right quantity, and the right time for the right patient. On the next slide, you'll see the mechanism of resistance. I will not stay on this slide. You can saw it that the gene plasmid mediated covalent chain, but it's not so important. On the clinical indication, what say the EUCAST? This is the colistin breakpoints. It's still the same. Nothing changed from 2021. In 2025, it's the same guidelines as it was in 2021. The colistin should not be used as a monotherapy. That's a key home message. Do not use it as a monotherapy. Use it in high doses. You can use it as monotherapy if you use high exposures and if it's a urinary tract infection. For systemic infection, colistin must be used in combination with another active therapy. Even if it's not sensitive, use it to potentiate to make a synergic effect. In this circumstance, the breakpoints and the ECOF in the breast can be used for distinguish between all microorganisms with or without acquired resistance mechanism. If you're not using correctly, you will have resistance. You will develop resistance to colistin. So be careful at the administrations. So as this is my last slide, so I wish you all the best and thanks for your taking your time to say. From my Sunny Timișoara, I will say all the best, and in case you have any questions, I will glad to answer.
Дуже дякую за вашу лекцію.
Thank you very much for your lecture, so highly esteemed professor. And now we've got a number of questions to ask from the colleagues of ours. And I can see that we have taken longer time than intended, so 2 or 3 questions, and then the professor so promised really to write back the questions later on via email. Very interesting question to ask. So the colleagues really saying that, so EUCAST methodology, susceptibility to tetracyclines, so defined by tetracyclines, and separate, so doxycycline goes. And in your lecture, you've been saying that susceptibility might vary depending on tetracycline in question. Do you need really to test each so representative of the tetracycline cohort? And what is your take about the cross resistance in among the tetracyclines?
In our lab, we are using only tetracycline for according to EUCAST thinking. That's how we are doing. We are doing in 2 methods. We are doing the testing on this diffusion method and on a MIC using a sensititer. But we are testing tetracycline.
Дякую за відповідь. Я просто
Thank
хочу
you for your
уточнити,
answer. I just would like really to you to be more specific. So we would like really to expect cross resistance to tetracycline, so susceptibility to doxycycline. So that means you will expect tetracycline to all of the representatives from this cohort. Do I get it correct?
So if the tetracycline is sensitive, we give them sensitive, and if the tetra is negative, we test it separately for doxa and for minocycline. Do you understand?
Зрозумів. Тобто ви
Message
ставите
clear. So
окремо
in other
диски
words,
і
so you have separate discs separately additionally for doxycycline and aminocycline. Thank you very much for your answer. Next question to ask here.
Наступне питання з
So next question to answer goes as follows. So in relation to cholestyne, because you talked about the importance of its combination, and sometimes I come across these questions asked and the problems relating to the correct perception of it. The question asked, what do you think about combining cholestyne with azithromycin for carbapenem-resistant gram-negative bacteria?
With erythromycin, you told me. Cholestyne with
Azithromycin.
азітроміцином.
tetramycin or
Azithromycin.
azithromycin. That's the cholestyne with azithromycin is not a typical combination. So it can be used only for resistant germs where can be used, but it's not so commonly used. The azithromycin has poor activity on gram-negative rods, for example, due to a poor outer membrane penetration. And cholestyne, for example, disrupts the outer membrane. So you can use it. On the several studies, I think that this synergic effect of cholestyne with azithromycin goes perfectly on Pseudomonas aeruginosa, on Acinetobacter baumannii, and on Klebsiella species, including the carbapenem-resistant strains. I don't know if it's we don't use it in our country, but I read it and it's not part of the standard guidelines yet. So it's not standardized until now. Most of the cases, most of the articles say that cholestyne and azithromycin goes perfectly against Acinetobacter baumannii highly resistance, and I think that's an options. Thanks.
Дуже чудово, дякую за відповідь.
Thank you very much for this extensive explanation, Florin. Let me add, just as a continuation to this discussion, just a bit. What I saw on the literature most often is that it is recommended to use cholestyne to beta-lactam antibiotics, specifically meropenem. Even if you have resistance to meropenem, cholestyne plus meropenem could really be a very good idea. Do you agree to that?
Most of the cases we are in our hospital we're using carbapenem with cholestyne because the somehow the carbapenem is potentiating it's much more clinical use than the colistin with azithromycin. That's my personal thinking. I think that they have a synergic effect, which had been shown especially to Klebsiella, to Acinetobacter, and to Pseudomonas. That's the classes that I will recommend. And I think that if you use this combination, you will reduce the emergence of the resistant strains.
Чудово, дуже дякую за відповідь.
Thank you very much indeed. Thank you very much for this answer. And the last two questions probably, and then we wrap up our session. A very interesting comment from our colleagues on the chat. They say that for pregnant women in Ukraine, they like to prescribe spiromycin antibiotic to pregnant women in Ukraine. Do you use it in gynecology and in for pregnant women? Spiromycin.
Spiromycin, we don't use it. I don't know if we have it on our market. I think that's it's an old. It's one of the. It was one of the preferred antibiotic during pregnancy, but it is delisted now in our country. But I know that it's still used in toxoplasmosis, especially to patients with infected to Toxoplasma gondii. So we don't have it on the market.
Зрозумів, дякую, зрозумів.
Got it, thank you. So that's about some local peculiarities probably. And the last question probably, a more extensive one, if I may, a bit out of the topic of our today's discussion. But the colleagues ask, what could be your recommendation with regards to guidelines or recommendations for diagnostics and identification for wounded patients? What could be the microbiological testing or approaches for wounded patients?
The wounded patient, it depends what kind of wound do you have. If you talk about the wound comes from an infected things from the war, for example, it's quite important to make the difference between the infections and contagious. That's one of the most important thing. If you'll have polymicrobial germs there, but it's very important to extract the right germs for the right infections. For example, the patient who suffered different accidents during the things can be if it's not a clean surgical wounds. We discussed about the wounds which can be due to surgical infections. That we can have skin flora like Staph aureus and Streptococcus epidermidis. That's the most common germs from there. If it's a contaminated traumatic wounds, which can come from the war, for example, you can have polymicrobial, which includes Staphylococcus, Streptococcus, all sorts of the Enterobacterales family, Pseudomonas, and be very careful at anaerobes bacteria there. And if it's a burn wound, that's a tricky one. The burn wounds, it's hard to treat, hard to diagnose, and hard to manage, because you'll have not only Staphylococcus, but you'll have a lot of germs which love wounds, burn wounds. You'll have Pseudomonas, which is highly complicated to be treated. Okay, you'll have other type of wounds. If you have bite wounds, for example, by dogs, by animals, whatever, you'll have Pasteurella. So be careful of that kind of germs, which comes from the bites. Even human bites, it's consisting of Pasteurella multocida, and be very careful at Echinochala. It's rare, but it can appear to wound bites. And another important aspect, I don't know how you stay with the number of patients with diabetes, but we have large number of diabetes in Romania because we like to eat and drink. That's the problem in Balkans. So it's all the food ulcers, which is also a wound infections. It's a polymicrobial infections, especially Staphylococcus enterobacterales, and don't forget Pseudomonas there. But careful with the contaminants, because I had a lecture 2 weeks ago about several unknown bacteria, and in my last 27 years, I've never experienced that kind of germs in my lab, so I quite have some experience. So be careful of contaminants and real pathogens. Thanks.
Дуже дякую, пане професоре, за вашу
Thank you
відповідь.
very much, Professor. Thank you very much for your answer. Probably we have exhausted the list of all questions we have had. Moreover, I would like to add for your information that we have lots of thank you and words of gratitude on the chat box. And I would like also to join the group of my colleagues and thank you very much for an outstanding lecture, for brilliant information. Thank you very much for additional information. Thank you very much for provided answers. Absolute words of gratitude to our dear colleagues from ICAP for organizing it, to our interpreters. We will continue the cycle of our webinars, so please follow our webpage of the Ukrainian Public Health Center and join our further events. Wish you have a nice day and peaceful skies above. All the best.
Thanks for your invitation. I want to say that all this work is not as part of a great team working. I'm not alone. I have a lot of support of my colleagues, young colleagues, who is doing a lot of research than me. I'm just a voice, and I have in the back a lot of other friends who is joining us. Thanks for to let me sharing my information, and we'll see you in Ukraine in a couple of weeks. So if you have some ideas about, if you want to send me some questions, you have my email. You can write me. Sarah have my mobile phone. You can text me on WhatsApp, so I can ask you briefly. If you have some cases that you cannot be solved, I am pleased to share my information, and we can text more easily.
Ще раз дякую. Тоді ми будемо
Well,
завершувати.
thank you very much indeed. Once again, I suggest we call it a day and let's keep in touch. All the best. Have a nice day.
Okay. Bye.